Hi everyone. I also work with NCCMH. I work on the more research side of the NCCMH. So we kind of tend to work more on evaluations and things like that. Some of our projects are completely separate to the QI side. This one is a little bit more linked. So we were looking at, instead of the inpatient smoking services, we were looking at services that were being set up in the community. So just as a bit of a background, there were 7 early implementer sites that got some funding to set up these community tobacco dependency treatment services for people with mental health conditions. These are the early implementer sites we've got. It's very split up here as 3 separate models of where people receive their referrals. I think actually it's not that separate in reality. I think a lot of the sites have been quite adaptive and they've taken referrals from lots of different places, which I think is definitely a good thing. And you'll see that as well with the kind of things I'm going to talk about. The other thing I wanted to say was we've started our kind of evaluation process, but the evaluation is more learnings that we can take forward so that in the future more sites can set up these services and kind of already be aware of the kind of things that will help them and the kind of barriers that they might face, so we can stop those being barriers before they become one. So it's not necessarily an evaluation in the way that you might always think of an evaluation as, are these targets being hit? So at the moment, what we've done is we've spoken to the people on the ground, the people helping to set up the services, a lot of the site leads, and we've asked them to tell us what are the things that helped and what are the things that didn't. And there were lots of other questions in a survey that we asked people to fill in. But these are the main things I'm going to talk about today because I think they're the most powerful in terms of learnings we can take from this so far. So this is just a list of the facilitators that we had reported. The numbers are the number of times that people endorsed this. So you can see that a lot of the things that were helpful were, for example, stakeholder interest and support. And I think that's something that a lot of people can kind of take on board and take away, that it's really important to get people who know the area to be interested and help you out where they know ways that can help you set up your service. Another one that was quite commonly reported was making use of existing infrastructure. So having protocols in place was a really often cited reason that helped people set up their services. There was another site that mentioned to us that kind of the stakeholder support then led into kind of in-house recruitment opportunities, which helped quite a lot as well. And then linked to that again, this idea of prior knowledge and experience, having contacts with people, it all feels quite linked, and I think there's quite a clear message there of what in the future we can do to help set up these community mental health services. Alongside that, we asked people what were the major hurdles that they faced, and the major one was uncertainty of funding, and I think this is something that will resonate with a lot of people in this room. This then had knock-on effects with recruitment of staff. For example, having to recruit for short-term contracts was a real problem, and just general uncertainty around it as well, I think, made the setup of the services quite difficult and was a problem for motivation as well. Some other things that were endorsed by just one site were kind of the very short expectation of timescales. I think was quite a difficult barrier because it felt a bit demoralising when people felt like they were behind, but actually the timescales were so tight that it just felt quite difficult. Again, the kind of trouble with recruitment of staff, going back to trouble finding people with the relevant experience. We heard in earlier talks that it's really important to have someone with that mental health expertise. I think people have found it quite difficult to recruit staff with expertise in both smoking and mental health. And yeah, the lack of time and capacity generally, alongside the fact that everyone is really, really busy in the NHS. I think the amount of funding that people had, and there wasn't enough kind of additional time given to prioritising this work. This is quite a short presentation, so I'm just going to finish off with what were some of the things that our site said to us. If they were doing it again, what would they do differently? Or if they could talk to another site that's just about to set up their services, what would they say is really important? And I think it really kind of echoes the facilitators that I spoke about earlier. So giving more reasonable timescales for setting up the service, engaging stakeholders early on, putting the kind of key infrastructure in place early on. It was mentioned about having a very personalised service. So I think a lot of people felt a little bit limited by having to get referrals from specific pathways, and that kind of links into what I was saying earlier, that some people have said, well, we're actually going to take referrals from anywhere, which I think is useful. And I found that last one on there quite useful as well, that large-scale communication strategy. So making sure that everybody who can refer patients is aware of where they can refer patients to, how that process works, to make sure that no one is getting missed in the process as well. So that's all from me.
Thanks very much.